Myocardial imaging, PET, metabolic evaluation study, including ventricular wall motion S and/or ejection fraction S, when performed, single study. 78,429 with concurrently acquired computed tomography transmission scan. A CT scan is performed concurrently with the above described PET study utilizing a combination PET/CT camera. Myocardial imaging, PET, perfusion study, including ventricular wall motion S and/or ejection fraction S, when performed, single study, at rest or stress, exercise or pharmacologic. Multiple studies. With concurrently acquired CT transmission scan. Multiple studies. Myocardial imaging, PET, combined perfusion with metabolic evaluation study, including ventricular wall motion S and/or ejection fraction S, when performed, dual radiotracer, e.g., myocardial viability. With concurrently acquired computed tomography transmission scan. A myocardial viability study is undertaken using dual radiotracers such as rubidium-82, to measure blood flow, and 18F-fluorodeoxyglucose or FDG, to measure whether heart muscle cells are alive, that are administered to the patient by intravenous injection. Absolute quantitation of myocardial blood flow, ACMF, PET, rest, and pharmacologic stress. The physician performs absolute quantitation of myocardial blood flow during rest and pharmacologic stress using positron emission tomography, PET. Brain imaging, PET metabolic evaluation. Perfusion evaluation. In PET imaging of the brain with metabolic evaluation, the radionuclide is injected intravenously and carried to the brain where the scanner detects the radioactivity as the compound accumulates in different regions of the brain. By using specifically tagged compounds, information on glucose, oxygen, or drug metabolism in the brain is obtained. Tumor imaging, PET, limited area, e.g., chest, head/neck, skull base to mid-thigh, whole body. Tumor imaging, PET, with concurrently acquired CT for attenuation correction and anatomical localization, limited area, example chest, head/neck, skull base to mid-thigh, whole body. In PET tumor imaging, information about the tumor's glucose and oxygen utilization is obtained, which reveals the tumor's behavior compared to normal tissue or benign tumors. Transcatheter therapy, embolization, any method, radiological supervision and interpretation, RSI. A local anesthetic is given at the puncture site and a needle is inserted into the selected vessel followed by a guide wire. The needle is removed. A catheter is inserted over the guide wire and advanced to the vessel requiring treatment. A blocking agent is injected or inserted and monitored. The effect may remain permanent or require another transcatheter embolization with time. This code reports the radiological supervision and interpretation only. Angiography through existing catheter for follow-up study for transcatheter therapy, embolization, or infusion, other than for thrombolysis. A radiopaque contrast medium is injected through the catheter and by fluoroscopic images recorded of the vessel, the radiologist interprets the status of the blood vessel and the effectiveness of treatment rendered. Mechanical removal of pericatheter obstructive material, e.g., fibrin sheath, from central venous device via separate venous access, RSI. The pericatheter material is identified by contrast material injection. Generally, a right femoral vein access is used. A guide wire followed by an angiographic catheter are advanced into the superior vena cava and exchanged for a loop snare with its catheter, which are advanced cephalad along the length of the central venous catheter beyond the ports. The loop snare is tightly closed about the CV catheter to encircle it and slowly pulled down and off the tip of the catheter, stripping off the pericatheter obstructive material. This is repeated a few times and the catheter is rechecked for infusion and injection ability of the ports. A contrast study is done again to identify any fibrin and the process may be repeated until the fibrin sheath is completely removed. This code reports only the radiological supervision and interpretation required for this procedure. Mechanical removal of intraluminal, intracatheter, obstructive material from central venous device through device lumen, RSI. The obstructing material is disrupted and removed mechanically by using an angioplasty balloon or other catheter introduced into the central venous catheter through its entry site on the skin. The catheter is checked for unimpeded, restored flow and the process may be repeated until the CV catheter is cleared. Endovascular repair of descending thoracic aorta, e.g., aneurysm, pseudoaneurysm, dissection, penetrating ulcer, intramural hematoma, or traumatic disruption, involving coverage of left subclavian artery origin, initial endoprosthesis plus descending thoracic aortic extension, S, if required, to level of celiac artery origin, RSI. 75,957 not involving coverage of left subclavian artery origin, initial endoprosthesis plus descending thoracic aortic extension, S, if required, to level of celiac artery origin, RSI. The endoprosthesis, contained inside a holding device, is introduced into the artery under fluoroscopy and positioned at the target zone area of repair. Extension prostheses may be required to the level of the celiac artery origin. In 75,956, when the endoprosthesis is in position, it is deployed within the artery at the target site in the descending thoracic aorta, covering the origin of the left subclavian artery. A balloon angioplasty may be necessary to achieve proper positioning and functioning of the endoprosthesis. The placement position is confirmed, the catheter is removed, and the arteriotomy site is closed. Placement of proximal extension prosthesis for endovascular repair of descending thoracic aorta, e.g., aneurysm, pseudoaneurysm, dissection, penetrating ulcer, intramural hematoma, or traumatic disruption, RSI. Placement of distal extension prosthesis, S, delayed, after endovascular repair of descending thoracic aorta, as needed, to level of celiac origin, RSI. The target site is identified by aortography and the proper extension prosthesis is selected. Under fluoroscopy, the extension prosthesis, contained inside a long plastic holding capsule, is threaded through the arteries to the site of the leak. Once the extension prosthesis is in place, the holding capsule is removed. The extension prosthesis, activated by heat, expands like a spring and becomes anchored to the artery wall at the site of the endo leak. If full expansion of the prosthesis does not occur automatically, a balloon catheter is threaded to the graft site and inflated within the endovascular prosthesis until full expansion is achieved. The placement position is confirmed, the catheter is removed, and the arteriotomy site is closed. Transcatheter biopsy, RSI. The biopsy catheter may be inserted through an already existing drainage tube or catheter, through a tract or pathway, such as the urethra during cystourethropy, or through the skin and into the access artery. Fluoroscopy is used to guide the catheter through its course from entry to the point of study to be biopsied. A biopsy brush, fine biopsy needle, or biting forceps may be inserted through the catheter to obtain the cells or tissue for examination. Change of percutaneous tube or drainage catheter with contrast monitoring, e.g., genitourinary system, abscess, RSI. An existing percutaneous drainage tube or catheter, example genitourinary system or abscess, is replaced with contrast monitoring. A guide wire is usually inserted into the existing catheter to guide the new one. The old catheter is removed and the replacement catheter is threaded back over the guide wire. Contrast injection allows for correct positioning to be visualized with fluoroscopic images displayed on a screen. Radiological guidance, i.e., fluoroscopy, ultrasound or computed tomography, for percutaneous drainage, e.g., abscess or specimen collection, with placement of catheter, RSI. A catheter may be advanced over a guide wire inserted through the needle and into the abscess cavity. The tract to the outside is dilated to facilitate placing a percutaneous drainage tube. The cavity is aspirated and the drainage tube placed at the lowest point to ensure complete drainage. The drainage tube is secured to suction drainage. Fluoroscopy, up to 1 hour physician or other qualified healthcare professional time, other than 71,023 or 71,034, e.g., cardiac fluoroscopy. A radiologist or other qualified healthcare provider supplies separate fluoroscopic monitoring of the body for up to 1 hour for procedures that do not include fluoroscopy as an integral component. Cineradiography/videoradiography, except where specifically included. To complement routine examination. Cineradiography uses high-speed X-ray films to take a series of images of an organ or system in motion such as the vocal cords or heart. Consultation on X-ray examination made elsewhere, written report. A radiologist provides a consultation and a written report after reviewing an X-ray exam that was performed elsewhere. (3D) rendering with interpretation and reporting of computed tomography, magnetic resonance imaging, ultrasound, or other tomographic modality with image post-processing under concurrent supervision, not requiring image post-processing on an independent workstation. Requiring image post-processing on an independent workstation. The physician provides concurrent supervision for image post-processing of computerized tomography, CT, magnetic resonance imaging, MRI, ultrasound, or other tomographic modality with 3D manipulation of volumetric data sets and image rendering. Mr. Brain spectroscopy. Magnetic resonance spectroscopy, MRS, is used to determine chemical and metabolic properties of a particular region, organ, or structure within the body. Mr. Elastography. Magnetic resonance elastography, MRE, is used to identify hardening of tissue, particularly liver tissue, since liver disease often causes fibrosis or scarring, which contributes to the stiffness of tissue in people with a known diagnosis or suspected liver disease.